Good morning, everyone. We're so excited to have you at CareOregon's MOUD Medications, Maintenance, and Myths Meds Ed. If this is your first Meds Ed, we're super excited to have you. Thank you for being here. If you're coming back for multiple times, we're excited that you're coming back. This is one of many that we've done on substance use disorders and medication for opioid disorders. So there will also be a place that you can go back if this piques your interest to see past Meds Eds that we have provided. So today, we're going to be talking about medications for opioid use disorders, maintenance and myths. We're going to hope to increase comfort and awareness around MOUD treatment while helping to eliminate lingering myths. So thank you for being with us and being willing to dive in so that we can bust some myths. All right. We are approved for CME and CEU credit hours. There's oftentimes lots of questions about this, so these slides will go out with more information soon. If you are a part of any of these groups, you can receive CME and CEU credits, so the American Academy of Family Physicians, the Oregon Board of Pharmacy, and the National Association of Social Workers, indicating the different hours for each of those boards. And this is our agenda for today and our approximate timing. It's a really exciting topic, and so we might have to take a little bit more time on different topics or different subjects. So it's a little bit flexible, but this is generally what we'll be covering. So we're going to be here together for about 2 hours until 9:30 with content, and then we'll have a really nice Q&A at the end of the content. Our learning objectives today are how to initiate and maintain patients on buprenorphine for the treatment of opioid use disorders. We're going to talk about best practices for managing patients who use multiple substances while on MOUD. And then we're going to talk about how to incorporate long-acting injectable buprenorphine into clinical practices, so things like Brixadi and Sublocade. We typically develop these Meds Eds based upon questions that we get throughout the year from our providers, our network. So thank you for giving us these questions and helping us to develop a really nice Meds Ed to address them. All right, so before I hand it over to our fantastic presenters, I'm just going to give a little bit of a background on who they are. We have so much gratitude for both of you being here today with us and sharing your knowledge, but also your passion for the patient population. I've had the honor of working with both Lisa and Emily, and they are fantastic colleagues and just wonderful educators. So thank you both for being here. Lisa is an addiction medicine specialist and psychiatrist, so the unicorn at OHSU. She works as part of the inpatient addiction medicine consult service, which you might know as the IMPACT program at OHSU. It is a fantastic program that provides excellent substance use disorder treatment while someone's in the inpatient setting. And then she also sees patients in the outpatient setting in general psychiatry out of the OHSU internal medicine clinic. And then another really awesome piece about her bio is that she is the deputy director for the Oregon Echo Networked Addiction Medicine Program. So many of you may have taken those echoes in the past. If you have, you may have crossed paths. But those echoes provide statewide education in the management of substance use disorders. And we're actually going to put a link to the echoes, the addiction medicine echoes, into the chat so you can take a look and get engaged and join us on one of those sessions. They're really fantastic. And then I'll just move on. So thank you for being here to Emily, who is a clinical pharmacist at OHSU. She also works on the IMPACT program, so the inpatient internal medicine department on the addiction consult service. She has a special interest in serving folks who have substance use disorders and optimizing the care. So lots of education for other providers. Emily, for me, has been a go-to for questions around naloxone and best practices in the hospital setting. Always really open and happy to share her knowledge and information with a real passion for the population. So thank you, Emily, for being here as well. We're very happy and honored to have you both. And I think with that, we can hand it over to our presenters.
Well, thank you all for being here so early on a Thursday morning to talk about medication for opioid use disorder. We're going to review the basics, we're going to do some myth busting, and Emily is going to give us a wonderful overview of long-acting injectable buprenorphine. So to get us started off, I think most of us know that these medications for opioid use disorder, are life-saving. In the year after a non-fatal overdose for patients who presented to the emergency room, those that were started on either methadone or buprenorphine had a decrease in their all-cause mortality. And this is this decrease in mortality is a larger reduction than we see with starting patients on antihypertensives, diabetic agents, statins, or even aspirin after having a STEMI. So I really think about getting patients with opioid use disorder stabilized onto medication, either buprenorphine or methadone, as one of the most important things that we can do in medicine and healthcare to reduce mortality. However, patients are not getting treatment. Even though we have these wonderful, effective, life-saving treatments, 87% of people with opioid use disorder do not receive evidence-based treatment. We're starting to see a little bit of a turning of the tide. Rates of prescribing are increasing, and this is largely driven by office-based buprenorphine, but it really hasn't been fast enough to keep up with the need. And looking at the data, actually, Oregon has been doing a pretty good job. Rates of MOUD have increased 140% from 2010 to 2019, specifically in Oregon. So our office-based buprenorphine prescribers are really picking this up, but we need more. When I think about the reasons why people are not getting this care, there's so many complex factors. But I think one of the biggest pieces is siloed care. Telling a patient, you can't get treatment here, you got to go over to this other special facility where they're going to take care of your addiction. You got to have this long wait time. Maybe they can't get you in for weeks or months. And a lot of those specialized treatment facilities, we just don't have enough of them. There are a lack of treatment facilities for addiction and substance use disorder care. So as much as we can bring buprenorphine medication management for opioid use disorder into primary care, into the hospital, and make it accessible for everyone who needs it, the more we can start to break down that silo and that barrier. Fear and stigma are also big reasons why people don't get treatment. This is something that's really prevalent and something I see all the time in the patients that I'm working with. They're afraid to disclose their substance use and to talk about it. They're afraid of being treated differently. I think it's something Emily and I see in the hospital all the time, and I'm sure you all see in your practices as well. And then there's also provider comfort and knowledge in treating substance use disorders. I certainly didn't get comprehensive education in this when I was training in medicine, even within the past 10, 15 years. This is something that I think medical education around this is improving. But having the comfort to use these medicines is an important part of this. And that's what we're addressing today. So thank you all for being here. And then things like cost insurance coverage. That's something where we're making great strides in Oregon around being able to provide these medications under Oregon Health Plan, and really appreciate the strong work of our payers and being able to improve access. But throughout the U.S., this is something that remains a big challenge for patients being able to get the care that they need, the medications that they need. So there are going to be a number of cases that are threaded through our presentation today. All of the names are made up, but these are loosely based on cases that Emily and I have seen. So our first patient is Jane. She's a 59-year-old. She's coming into your office asking for help stopping fentanyl use. She was previously using heroin, but transitioned to fentanyl about 3 years ago. She's had 5 years of abstinence in the past when she was using heroin and was stable and taking buprenorphine. She was on a stable dose and said, boy, that really worked well for me. I really want to get back on buprenorphine. But ever since I started using fentanyl, I just can't do it. This is different. I'm struggling in a way I didn't expect.
Okay, let's explore buprenorphine a little bit more to see how we can help Jane start buprenorphine. So just some basics that I want to highlight. These are important pharmacokinetic properties of buprenorphine that will play into understanding how we transition patients over to buprenorphine. So bup is a partial opiate agonist. The partial description of it, I think, is very misleading. The partial does not apply to analgesia. It still reaches a receptor activation threshold to achieve analgesia. The partial part of it, I like to think of it as applying to the side effects for it. So buprenorphine has less sedation, it has less euphoria, you get less respiratory depression, and certainly less constipation than you do with other full opiate agonists. And so the partial should really just apply to the side effects, and we shouldn't apply that to the analgesia part of buprenorphine. It still is a pretty good pain reliever. So there's not great MME conversion out there, but generally we think that 1 milligram of sublingual buprenorphine is around 30 or 40 oral MMEs. So certainly significant. Buprenorphine also has fairly high affinity at the mu receptor, and so it'll outcompete any other opiate that works on the receptors in the brain. It has a really long half-life. It'll stay on those receptors once it gets there for anywhere from 24 to 36 hours. And the bioavailability is really formulation dependent. And this is important when we're talking about transitioning from certain formulations. So there's sublingual tablets, there's buccal films, there's patches that are out there, and they all have different bioavailabilities. And so 1 milligram of the sublingual tablet does not equal 1 milligram of the buccal film. And so just really paying attention to the bioavailability of each specific product. And then the peak is in 1 to 3 hours. The mu receptor availability I bring up, really it comes into play when I'm starting thinking about using concurrent full opiate agonists. So this is a myth that comes up fairly frequently, is that you can't achieve good pain control while on buprenorphine. And in real life, we don't see that being true. And when we look at the receptor occupancy that buprenorphine has, you still have, even at the highest dose of buprenorphine of the 32 milligram sublingual, you still have a significant amount of mu receptors that are open and available for the full opiate agonist to work upon. And so you still can get good pain control even on the highest dose of buprenorphine. The serum levels I bring up when it comes into play when we talk about the long-acting injectable buprenorphine, the 2 nanogram per mil serum level is really what those drug companies emphasized, and that was their target serum level. Is based on pretty small sample size. They found that euphoria was blocked at around a serum level of around 2 to 3. Also, when the serum level is above 2, you do get some protection against respiratory depression from other full opiate agonists, so fentanyl, hydromorphone, morphine, things like that. So fentanyl in the drug supply, I think we all know that fentanyl is a problem. It's the predominant illicit opiate found now. The 2 words I like to associate with illicit fentanyl is potent and lipophilic. The stuff is really strong. It's 100 times more potent than heroin. It's 500 to 600 times more potent than the prescription morphine that's out there. It's also lipophilic, which essentially means that it will very quickly cross into the central nervous system and exert its effect on the brain. It won't stay there for very long, however. It fairly quickly redistributes out into the rest of the body and hangs out in the muscles or the fatty tissues for days. And the shorter duration of action in the brain is what makes people need to use more frequently to not experience withdrawal. So how to start buprenorphine? Currently, there's 3 main transition ways. We'll go into each of them a little bit more detail. So this is just a high overview of the 3 different ways that you can start your patient on buprenorphine. The standard, it's been around for decades. This has gotten a little bit tricky in the setting of fentanyl. It worked fairly well in the era of heroin, but with fentanyl, the standard way to induce patients gets a little bit complicated. There's high dose, which is the new kid on the block, which takes a lot of the same concepts that standard induction uses, but just triples or quadruples the initial starting dose. And then there's low dose, which is my personal favorite. And it is a way to transition patients where they don't have to experience bad withdrawal or severe withdrawal that you would with a standard or the high dose, and it reduces the risk of precipitating withdrawal. Unfortunately, it has fairly complicated dosing instructions, and you still need to use some type of full opioid agonist in the background. So that could be some complicating factors when considering which way to transition your patients over. Always involve your patient in shared decision making. So you have these 3 ways that you want to start your patient on buprenorphine, talk to them, and really engage with them and what feels right for them and how they want to transition. So important questions to ask or topics to dive into is what their past experience, what worked for them in the past, what didn't work, what went horribly when they had used the standard way to transition over, and kind of work through some of the bad experiences that they had and ways that you can avoid those bad experiences from happening again. It's also important to explore what kind of support and resources they have. Do they have a safe person to do the transition with? Do they have a safe place to sleep afterwards? Do they have access to a bathroom if you're doing the high dose induction? Those are all important things to think about. Dose changes as well. So with a low dose initiation, the doses change really frequently, and there's multiple times a day that you have to use different dosing. And so is a patient able to keep track of complex dosing changes? Drug supply. Do they have access to their same supply so they can use that in the background of the full opioid agonist? And then withdrawal tolerance is another important thing to explore. What level of withdrawal are they willing to tolerate and for how long? If they have a very low threshold to withstand any withdrawal, then maybe low dose induction could be the best method for them. If they're okay with some intense withdrawal and just wanted to get it over with and get onto buprenorphine quickly, then maybe the high dose could be the right transition method for them. These are just some counseling points, so some sentences or verbs that you can use to engage your patients in the shared decision making. The slides are all available for you, so feel free to use any of these as you feel would apply to your clinic space or your practice, I guess. So the standard. It's important to make sure that the patient knows that they do have to be at least in moderate or severe withdrawal. Ideally, you would wait till 24 hours after their last fentanyl use. You could do it a little bit sooner, just know that you would have a risk of precipitating withdrawal. It's important to know that you'll prescribe them comfort medications to get them as close to that 24-hour mark as possible, and then explain to them what the purpose of each comfort medication. So I'm going to prescribe you tizanidine when your muscle spasms get really bad. This is a medication that you would use for your muscle spasms. And then also, it's important to note that with the low dose, you start at a dose of usually 2 to 4 with a standard dose. Sorry, Lisa, you can go back. Start at the standard dose. Your initial dose is small. It's going to be around 2 to 4 milligrams that you start with, and then you have to take that every hour. And so it could be that you're dosing quite frequently throughout that day, and so making sure that day's free for them to take the buprenorphine potentially every hour until they can get to a standard dose or their therapeutic dose. Low dose, these are some talking points, is that this could be a good method to transition if you do not want to experience withdrawal or severe withdrawal. I think it's important to note that the patient could still feel something, and so it's not you won't feel any type of withdrawal at all. It just won't be severe. It should be fairly mild, and that they do have to keep track of complex dosing. So they're going to have to go from a 0.5 milligram to 1 milligram. They're going to have to split tablets or films. And just be really on top of taking their buprenorphine doses. This method, you can also elect to choose, you can do a rapid one where the patient transitions over in 3 days, and so it could be more intense for them over their 3 days, or you could spread it out and do it over 7 days. And so also engaging with them, what transition duration feels right for you, 3, 5, 7, 10 days, and really talking through that with them as well. It's also important to note that they will need access to their regular supply of opiates. And so having an overdose conversation with them, talking about harm reductions and safer use, and then also really ensuring that they have naloxone available to them. And then for high dose, this is really important to know that the patient has a fairly high risk of precipitating withdrawal, especially if they start the buprenorphine sooner than 24 hours after their last fentanyl use. So talking about how you'll manage precipitated withdrawal if it happens will be important. Having a strong support person there, having access to the bathroom while they're waiting for that 24 hours mark to take their buprenorphine is important. And then also a safe place to sleep afterward. They'll likely be tired from the 24 hours of withdrawal and then from the buprenorphine. And so making sure they have a safe space to rest afterwards will be an important counseling point. Okay, so let's go into the dosing specifically. So standard initiation, there's lots of data out there on this one. These doses are really easy to find. General concept is you would wait till the COW score is greater than 10, and then you would do 2 milligrams, the patient would take 2 milligrams. The COW score, I think, was fine in the setting of heroin. It has been less reliable for us, especially in the setting of fentanyl. So I don't always love using a COW score. I think using 2 objective withdrawal symptoms in counseling the patient to use that instead of necessarily a COW score. And also just saying, when you feel like your withdrawal is really bad, patients generally know when they're in enough withdrawal where buprenorphine won't make them feel worse, that it'll make them feel better. And so really relying on the patient experience will be good in the standard initiation. But then once they take the 2 milligrams, they'll repeat that every hour until they get to a dose where they don't have any cravings or withdrawal anymore. And then on day 2, they will have to keep track of the amount of doses that they took. And then on day 2, they add up the total amount that they needed to feel okay, and then take that as a single dose the next day. Low dose initiation, I think this is really great, especially on the inpatient setting where we can control the dosing. There's a MAR, the nurse can bring them the medication, they don't have to keep track of it. It's also really great in the inpatient side, as most patients who present to the hospital also have some indication for acute pain needs. And so you can really also then continue standard of care, which would be full opiate agonist, in addition to transitioning them over to buprenorphine. It certainly can be done in the outpatient as well. It is just a little bit more tricky, and more things could go wrong on the outpatient side than it can on the inpatient side. But low dose initiation, the theory behind it is that repetitive administrations of small doses of buprenorphine won't precipitate withdrawal. So we sneak in really tiny doses of buprenorphine. We give them 0.5 milligram, and then we give them 1 milligram. And because buprenorphine has a long half-life, it's going to stay on those receptors for 24 or 32 hours. You give small doses, and eventually the buprenorphine will overcome the mu receptors and in the brain and overtake that versus the full opiate agonist. It's essentially what it is dose stacking. Generally in healthcare and with medications, we don't like to dose stack medications. You can get into trouble that way. But with buprenorphine, this is exactly what we want to do. We want to stack that dose and eventually take over the mu receptors from the full opiate agonist. Once you get to around 8 milligrams on the low dose initiation, we think that there's enough buprenorphine on those receptors that you won't precipitate someone. And so then you can make larger dose adjustments after that. So that 8 milligrams is really the key to get to your patients too. There's lots of different dosing strategies out there. This is the one that we use in our hospital that has worked fairly well for us. We can get patients transitioned over in about 4 days. There are published ones that can get them over in 3, that all the way up to 10 days. And so finding a transition dosing strategy that for low dose that works for you will be important, but there's lots of them out there. I do really like to point out that it is important to continue that full opiate agonist until you get to that 8 milligram blocking dose. All of the other doses of buprenorphine before are subtherapeutic, so will not treat their withdrawal symptoms. And so making sure that there's some type of full opiate agonist in the background. Once you get to that 8 milligrams, then whatever opiate agonist that you're using can go away. You don't need that. If they are admitted or they're on full opiate agonist for acute pain needs, those can certainly be continued still, but whatever opiate you're using to treat the withdrawal can go away after 8 milligrams. And then just make sure that we continue to titrate up. Very few patients will feel okay on only 8 milligrams. So oftentimes what that looks like for us on day 4, when they get their 8 milligrams in the morning, we'll give them another 8 milligrams at noon, and then another 8 milligrams in the afternoon, and generally get them up to closer to 16 to 32 milligrams on that day. In the ambulatory care space, certain insurance companies will still has a max of 3 films or tablets a day. And so depending on what dosing strategy you use, the 2 milligram tablet, you may need to use actually 4 of them a day, which the insurance company will reject. And so you do have to get a little bit creative when sending your prescription over to the pharmacy. So this is one that we've come up with as a workaround that really maxes it at 3 of the tablets a day. You do have to switch over to the 8 milligrams, and they do have to quarter them. And so talking through your patients of how to quarter the films or how to quarter the tablets will be important. The tablets are a little bit tricky to quarter as they are orally disintegrating, so a little bit crumbly. So just making sure that it won't be that the patient knows it's not going to be exactly a quarter of a tablet, but as close as to a quarter as they can get. So this would be an example of some standard buprenorphine prescriptions that you could send to a pharmacy that should be covered by most insurers. Also creating a dosing table for the patient to follow. The prescription that you send over there is going to be tight. You can't get a lot of information on that that will fit on the prescription bottle. So creating some type of table for that patient to follow, check boxes with them to say, oh yes, I've taken this 4 times today, or oh, I only took it 3 times. I need to take another one before the next day. And so that will really help them keep them on track. We have, as anyone's interested, we've developed an outpatient order set essentially that has all of the standard prescriptions, and we have a lot of patient dosing instructions and patient tables for anywhere from, I think, 3, 5, and 7 day transitions that I'm happy to share if anyone is interested in using or seeing that example. And then high dose initiation. The data really lies in the ED patient population, but we're certainly doing that in the ambulatory care space. We haven't done a whole lot of it in the hospital space. We really rely on that low dose induction, but this is certainly something that is done in more and more commonly. So with high dose initiation, I think it is really important to try and get to as close to the 24-hour mark from the last fentanyl use as possible. Make sure that you're prescribing or offering comfort medications while you're getting them to that 24-hour mark. And then once they get to that 24-hour mark and they feel like their withdrawal is really bad, then they would take a higher dose of buprenorphine. There's a wide range. It's anywhere from 8 to 24 is the initial dose. I'd say 16 is probably the most common, and that's the one that we use in our ED patient population. And so then at the 24-hour mark, they would take 16 milligrams of buprenorphine, and then they would take an additional 8 milligrams every hour up until the max of it. And so that will transition the patients much quicker than the standard will to a therapeutic dose. But there is a higher risk of precipitating just because that dose is a little bit higher. California Bridge, if you guys don't know about it, it's a great resource for all things buprenorphine related. They're really, their bread and butter is the ED, and so they have a lot of their dosing strategies is based in the ED patient population, but they're starting to expand and add more for outpatient, inpatient, but they have a lot of really good resources and even patient-facing resources if you wanted to check them out. This is their self-start guide for a high dose, essentially. And then there's this other transition method where it combines a little bit of low to high dose. Some patients can be quite fearful of the high dose induction just from precipitating and taking the buprenorphine, some anticipatory fear. And so this low dose where you give them 1 milligrams, 2 milligrams for a few hours, and that first every few hours for the first 24 hours, that can help kind of overcome some of the fear. And then again, once they get to that 24 hours, then they would take the much higher dose of usually 16 milligrams and transition that way. So that could be something that could be helpful for your patients too, especially if they're anticipating fear from taking a higher dose of buprenorphine.
All right, so now that we've reviewed all of the many different ways that Jane could start buprenorphine, let's ask her about some of the challenges that she's had so far. So you asked Jane about her recent experiences with starting buprenorphine, and she tells you that she's tried 2 low-dose starts recently. She says, I had trouble following the directions. The first time I took too much on the first day and felt sick, precipitated opioid withdrawal. The second time I used less fentanyl the first 2 days, thinking it would help, but I felt worse. So that second attempt, less likely that she had precipitated opioid withdrawal, but some people will start to decrease their full agonist and go into just general opioid withdrawal while trying to do these transitions. So she had some challenges with those two attempts at the low dose start, and that's fairly common. These are things I hear from patients pretty frequently that are trying this in the ambulatory care setting. So you go over the different ways to start buprenorphine, and Jane says she'd like to try a high dose start. She says, I know I'm not going to feel good the first day, but I just want to get this over with. She's interested in adjunctive or comfort medications that she can take while waiting to start the first dose of buprenorphine. So what are these adjunct medications? Emily alluded to one of them, tizanidine, which can help with muscle spasms. This table will be available for your reference. But what I like to do when I'm asking patients about their opioid withdrawal symptoms is I ask them, what are the symptoms that tend to bother you the most? Do you get more body aches? Do you get more muscle spasms, nausea? And then you can go through this like a menu. What medicines do I think are going to be the most helpful for you while you're undergoing opioid withdrawal, especially for people who are doing high dose starts, who may need to wait 24 to 48, maybe even 72 hours before they're taking that first dose of buprenorphine. So things like acetaminophen for pain, clonidine for anxiety or restlessness, gabapentin, which can also be helpful, hydroxyzine, ibuprofen. And really, the only reason not to think about prescribing one of these is if someone has a contraindication. So for example, I would avoid things like ibuprofen for people who are pregnant. But many of these medications can be used for most patients and can be incredibly helpful and provide that additional support while they're waiting to start buprenorphine. I also think about using these for patients undergoing low dose buprenorphine starts, not just those high dose starts, especially if someone is trying to use a little bit less fentanyl while undergoing that low dose start. This can still be helpful and supportive. Okay. So you see Jane back the next week. You give her all the prescriptions. She's going to do the start at home. And she says she was successful in starting buprenorphine. She's now on 24 milligrams a day. She waited a full 48 hours from her last fentanyl use to start buprenorphine. She did not have precipitated withdrawal. She did experience some moderate to severe opioid withdrawal symptoms while waiting to take the first dose of buprenorphine, but found the adjuncts helpful. And she was able to discontinue fentanyl use. And I just want to pause and say one of the reasons I presented this particular case, and I think I'm similar to Emily, I have a bias towards doing low dose starts. And I think that's because of wanting to minimize that experience of withdrawal. But patient preference and how they start buprenorphine is one of the most important things. And so when a patient comes in and tells me, I've tried a low dose start, or I don't think that method's going to work the best for me, even though I internally have that bias towards doing low dose starts, I think it's important that we honor what patients feel like is going to be the most helpful for them. So being able to offer a high dose start or something like a low to high dose start is very important. Okay, a couple notes on long-term dosing. So the ASAM National Practice Guideline recommends titrating dose to alleviate symptoms and to be sufficient to allow for discontinuation of illicit opioid use. One of our myths that we want to bust today is that the dosing max is 24 milligrams. That's something that I heard over and over and over again when I was doing my training and early on in practice. But really the dosing closer to 16 to 32 milligrams can support improvement in treatment retention, reduced opioid use, and lack of adverse events. And those dosing limits are often driven by things by outpatient insurance. So needing a prior authorization in some counties or with some insurances may be necessary for patients that are on 32 milligrams. But to highlight this point in just a little more detail, we're going to see our second patient of the day, and that's Sam. And Sam is actually loosely based off of someone I saw when I was a fellow in addiction medicine. So Sam is a 24-year-old. He has opioid use disorder, and he recently started buprenorphine 3 weeks ago. He's been taking 8 milligrams in the morning and 16 milligrams at night. And he's discontinued all fentanyl use, completely stopped. But he says, I'm still having chills, night sweats, body aches. I'm not sleeping well. I just don't feel right. I keep taking the buprenorphine and I've been able to stop using fentanyl, but this is not how I expected to feel 3 weeks out. He's still having cravings for opioids, and he wants to know, can he increase his buprenorphine? So he's on 24 milligrams a day, 8 in the morning, 16 at night. So the first thing I would do before considering a dose increase is reviewing administration technique. So buprenorphine has to be taken sublingually, and there's a number of different things that can make it more challenging for the medicine to be absorbed properly. So making sure that he is starting with a moist mouth. If you have a dry mouth, you're not going to be able to properly absorb buprenorphine. Not talking while letting the film or tablets dissolve. Certainly this is something I run into in the hospital all the time. I'll like give someone buprenorphine and then I'll like keep talking to them. And I'm like, wait, pause. We need to like make sure the medication dissolves before I keep asking you questions. But really like letting it sit under the tongue for a full 5 minutes, completely dissolve. And then holding that tab there after it's dissolved for an additional 5 minutes can be helpful as well to make sure that there's not going to be missed medication that's not getting absorbed. Not swallowing the pills or tabs. That's another big piece. A lot of people who don't get education on how to properly take buprenorphine will swallow them. The oral absorption is pretty poor. Emily probably knows the exact percentage of that's orally absorbed, but it's much worse than the sublingual, and it can cause a lot of nausea when someone takes the medication and swallows it. And then avoiding acidic drinks like coffee, fruit juice, or nicotine 30 minutes before taking it, as those can delay absorption. And then in terms of the dose limits, that 24 milligram dose limit is really based on data from before the fentanyl era. We had looked at the mu opioid receptor occupancy around 16 milligrams. It's about somewhere between 80 to 90%. And at 32 milligrams, it's closer to 94 to 98%. And that higher receptor occupancy is associated with reduced withdrawal symptoms and cravings for opioids. So there are a subset of patients that do better on 32 milligrams a day. And so, if you have a patient who just isn't able to discontinue fentanyl use or get stabilized on a lower dose, 16 to 24 milligrams, that is a sign that they might need to go up to 32. So for Sam, you decide to increase his buprenorphine to 16 milligrams twice a day or 32 milligrams daily. And he comes back to see you a week later and he says, my body aches are better, my chills are gone, I'm finally sleeping at night. My cravings for fentanyl are not completely gone, but they're greatly reduced. I feel much more able to work through this and keep working on strategies and skills to manage those residual cravings. And overall, he's feeling much better. And as I mentioned, this is based off of a real case that I saw, and I think that experience really changed my mind and encouraged me to look into the literature on what dose limits are. And this is something that has just become more standard as time has gone on, to be able to go up to 32 milligrams. So first myth busted, hopefully, is that if patients that need it, you can go up to 32 milligrams of buprenorphine. We are going to switch gears and spend some time talking about patients who use multiple substances. I think this is our second myth to bust for the day, is that patients who use other substances cannot be continued on buprenorphine, which is something that I also used to hear much more frequently. But I was curious what the actual data is. What's the literature on this? And so we're going to walk through some additional patient cases to see what's known about patients using multiple substances, and then we'll wrap up this section with some best practice guide on how to approach patients using multiple substances. So our third patient of the day is Marie. She's a 45-year-old woman. She has opioid use disorder, and she's been stable on buprenorphine 24 milligrams daily for the past 8 months. She presents today for a routine follow-up. She previously used fentanyl daily, but she's been able to discontinue, and she's been doing really well in treatment. As part of a routine care at your clinic, she does a point-of-care urine drug screen that comes back positive for buprenorphine and benzodiazepines, and she's not prescribed benzodiazepines. She discloses that she's been taking non-prescribed alprazolam from her friend's prescription. Super common scenario, something I see all the time. But I'm curious, what do we know in the literature? What can we do to help support Marie and help her be successful? So a place to start, the FDA has issued several safety communications, first in 2016 and then an updated one in 2017, about the risk of combining opioids with benzodiazepines. So in 2016, the FDA warned about serious risk of death when combining opioids with benzodiazepines. And if you read that FDA drug safety communication, a lot of what they are warning against is the co-prescription of opioids and benzodiazepines. And it's not specific to buprenorphine, it's not specific to medication for opioid use disorder. It really was meant to raise concern among like co-prescribing of these medicines in outpatient settings, but really wasn't specific to MOUD. They issued an updated warning in 2017 that urged caution about withholding opioid addiction medications from patients taking benzodiazepines or other CNS depressants. And I think that initial 2016 safety communication, some people interpreted it to mean that if that patient was on a benzodiazepine or taking non-prescribed benzodiazepines, they should be taken off of their MOUD or buprenorphine. And that updated safety communication helped correct that initial concern that we should really be working with patients, not taking them off of MOUD if they're using benzodiazepines or other CNS depressants like alcohol. So what do we know about use of benzodiazepines in the setting of being on buprenorphine? So benzodiazepines, either prescribed or non-prescribed, using those is extremely common in those who are on buprenorphine. There's so many different prevalence rates out there that it's hard to nail it down. You know, some papers say 30%, some say 50%, but it is extremely, extremely common. There is an increased risk of overdose when taken together, especially if the benzodiazepine is used IV or at supratherapeutic doses. And one way to think about this, because benzodiazepines can also suppress the respiratory drive, I think about it as removing buprenorphine's ceiling effect on respiratory depression. So someone is using a benzodiazepine or taking even a prescribed benzodiazepine, especially at high doses, we no longer have that protection against accidental overdose from that ceiling effect on respiratory depression. There is a study that's often cited out of Finland looking at buprenorphine poisoning or overdose deaths. And out of 182 people who died from buprenorphine overdose in between 2000 and 2008, in all but one case, either a benzodiazepine or alcohol was also found. And I think this is often cited to say if you're on buprenorphine alone, it's extremely uncommon that you're going to have an accidental overdose. It's really those cases we're seeing when people are combining buprenorphine with a benzodiazepine or alcohol. Because as an interesting side point, Finland is one of the few countries where the most common opioid of misuse is buprenorphine itself, which is kind of interesting. But you know, it is something that is a risk if combining buprenorphine with CNS depressants does increase overdose risk. There was another study that looked at patients who were in an outpatient buprenorphine treatment program, over 300 patients who had a prescription for benzodiazepines, and it did show that they were more likely to have accident-related emergency room visits, and that risk was greater in female compared to male patients. However, I think another myth that comes up is that if someone is either taking or using a benzodiazepine, they're less likely to remain engaged in treatment for opioid use disorder. But this study found no influence on treatment retention or illicit opioid use. So those patients weren't using fentanyl or other illicit opioids at higher rates. And there was no increase in overdoses and no fatalities in that group during that 12-month study. And so what they concluded from that study was that being on a benzodiazepine can increase the risk of accidents and injuries and emergency room visits, but it didn't increase mortality, it didn't increase overdoses, and patients remained engaged in treatment. The risk of opioid toxicity is higher when patients are using methadone and benzodiazepines. However, you know, I think that really the key point here is that the risk is much, much higher when benzodiazepines are used with fentanyl. So I think buprenorphine likely has the lowest risk combined with benzodiazepines compared to methadone, which is higher risk, and then fentanyl, which is extremely high risk for accidental overdose. The British Columbia Coroner Services reported benzodiazepine positive samples in 52% of fatal fentanyl overdoses in January of 2022. And I think my big takeaway from the past few slides is, yes, there is some additional risk. If you're taking a benzodiazepine or using a non-prescribed benzodiazepine and you're on buprenorphine, that is going to increase your risk of accidental injuries, overdose. However, that risk is higher if you're using fentanyl, extremely higher if you're using fentanyl compared to being on buprenorphine. I also want to take this, since I'm also a psychiatrist, as an opportunity to talk about co-occurring mental health disorders. Among people with opioid use disorder, co-occurring mental health disorders are extremely common. The most common one that we see is actually anxiety. 39% of people with OUD have anxiety. Depression and PTSD are also extremely common. ADHD as well. So it's looking at just these really, really high prevalence rates. It is not surprising to me that someone with an opioid use disorder would seek out a way to alleviate their anxiety. And I think this presents an opportunity. So an unexpected positive urine toxicology for benzodiazepines can be an opportunity to open the door to discuss why that person's using the substance. Are they not able to sleep? Do they have uncontrolled worry? Are they experiencing panic attacks, hyperarousal from PTSD? Or are they using it for the euphoric effects? Is that something that they may be getting that type of experience from? There's an interesting study that interviewed patients who were stable on buprenorphine who were also taking either prescribed or non-prescribed benzodiazepines. And I wanted to actually read some of the quotes from this because I think this is really interesting. They asked the patients themselves what their experience was being on benzodiazepines or taking non-prescribed benzodiazepines. One patient said just simple things like walking down the street would, really bother my anxiety. And now I don't have that feeling anymore, like I feel like I'm able to do normal things. Another patient says, I got prescribed Klonopin and I started taking 3 a day and then I started buying them. So I'd end up taking, I'd mix Xanax and Klonopins, then take them on a high dose of methadone, and I'd be pretty much high all day. So someone using it more for the euphoric effects. The first person, it seems like it was more to manage anxiety. And a third patient says, I don't take extra. I take them the way I'm supposed to now because I realize taking extra is just screwing myself in the end. And if you do take them the right way, they help with that, with what I want them to help with. I don't want the high anymore. I just need the anxiety taken away. So I think it's really interesting to see the variability. Some patients in the study were really using and taking benzodiazepines as the way to manage anxiety. Some were using it for euphoria. So I think each patient's different, and being able to sort out and get to the bottom of what that substance is helping with or not helping with, or what the underlying reasons why that person may be continuing to use that substance is really important as you figure out where to go next. Okay, all that being said, let's get back to Marie. So when you ask Marie about her experience, she reports having a long history of anxiety and panic attacks that long preceded her onset of opioid use. And she says she doesn't want to take alprazolam, but she's terrified of having withdrawal symptoms if she stops. She had a really hard time getting on buprenorphine. She had really bad opioid withdrawal. And she says, I just don't want to go through that again. I'm terrified of having that experience again. So you start her on a medication for anxiety, sertraline, and you refer her to see a therapist. You decide that you are going to, from a harm reduction standpoint, we need to get you off of non-prescribed alprazolam. Who knows what it is? It's from a friend's prescription. Do we know that it's actually a benzodiazepine? Could it be fentanyl? Well, sure, her urine drug screen was positive for benzodiazepine, so more likely it was truly a benzodiazepine. But whenever someone's taking something that's not prescribed, you never really know what's in there. It's if her goal is to come off of it, we're going to help her get off of it. So we decide to prescribe her clonazepam with a plan to slowly taper it. And she discontinues the non-prescribed alprazolam. She remains engaged in treatment for opioid use disorder, and she does not return to fentanyl use and is doing well the next time you see her. I don't have a separate case on alcohol, so I just want to pause and make a quick point that I think about patients who are on buprenorphine who use alcohol in a kind of a very similar way. They're both CNS depressants, and I think really working with patients around why they're using alcohol, what benefits are they getting from it, what are they concerned related to the use, and not stopping their medication for opioid use disorder, but helping them reduce or potentially come off of alcohol completely as a way to support them through that. And I would think about that with any CNS depressant. All right, now we're going to move on to Reese. Reese is a 21-year-old transgender male. He presents to your clinic for follow-up on opioid use disorder. He's been taking buprenorphine for 3 months, and he was successful in stopping all opioid use. This is really great. We have a lot of patients who are doing really well on buprenorphine. However, he continues to smoke methamphetamine daily, and he's afraid to discuss it as he's worried his buprenorphine prescription will be stopped. I think I mentioned this earlier. This is certainly something that I've seen, not recently, but several years ago, patients who were being taken off of buprenorphine because they were having positive urine drug screens for stimulants, and I wanted to know what the data was on this. So even more than benzodiazepines, stimulant use in those with opioid use disorder is extremely, extremely, extremely common. One study showed that for those entering treatment with opioid use disorder, over 82% had used stimulants at some point in their lifetime. And really the rates of stimulant use in those who are using fentanyl has skyrocketed to the point where we now call it a twin epidemic between fentanyl and methamphetamine. It's really common that they're sold together. Sometimes the powders are even combined into one product. I really think about fentanyl and methamphetamine as going very closely together. Having both an opioid and a stimulant use disorder does increase the risk of fatal and non-fatal overdose. So there is an increase in overdose risk, similar to what we see with combining opioids with benzodiazepines. And methamphetamine has been shown to be associated with lower treatment retention for opioid use disorder. All of that being said, being on a medication for opioid use disorder, so being stable on buprenorphine or methadone, is associated with a lower odds of stimulant-related ED visits or hospital admissions. So I think that's a really important point. There is risk combining opioids with stimulants. There is, some risk even for patients that are on those medicines, on medication for opioid use disorder. But if we can get someone stable on MOUD, their risk of stimulant-related admissions goes down. So for Reese's case, after being reassured that his buprenorphine will be continued, Reese feels more comfortable discussing his methamphetamine use. He says he's not ready to discontinue use, but he is interested in harm reduction measures, which leads to a very fruitful discussion about how he can reduce his risk of harm with continuing to use methamphetamine. And I think that this is an important point. If we can keep him engaged in treatment, we can keep him stable on his medication for opioid use disorder, we can decrease his risk for harm. Okay, our last patient is Alexa. She is a 68-year-old woman. She has a remote history of opioid use disorder, and she's been on a stable dose of buprenorphine now for 15 years. She is primarily taking buprenorphine for chronic pain at this point. She said, my opioid use disorder, that was a long time ago, but I've stayed on this medicine because it really helps with my pain. Her primary care doctor retired, and her new PCP will not refill her buprenorphine because her urine drug screen came back positive for THC. And she's coming in to see you now as a new patient to transfer care, and she's down to her last tablet of buprenorphine, and she is just terrified of going off of it. She says, I've heard people get really bad withdrawal. I want to continue this. It's helping me. What can you do? So buprenorphine and cannabis. So similar to other substances, there are high rates of cannabis use in those with opioid use disorder. And just in general, I just want to pause and say in Oregon, even for people without opioid use disorder, I'm just talking about the general population, there are really high rates of cannabis use. 32% of adults in general reported past year cannabis use in 2022 to 2023. So anyone you're seeing out there in the world in clinic, about 1 in 3 people in the state have used cannabis in the last year. And not to say any positive or negatives about cannabis itself, I just want to highlight how prevalent it is, especially in our state where we have legalized recreational cannabis. Tetrahydrocannabinol, or THC, and cannabidiol, CBD, have no known clinically significant interactions with buprenorphine. Cannabis use does not increase the risk of non-medical opioid use in those with on MOUD, and preliminary evidence shows that cannabis likely does not improve opioid cravings or withdrawal. So I really take this to mean it's probably not gonna be super harmful to an MOUD treatment plan. It's also probably not going to help much either. It doesn't really show that it helps with opioid cravings or opioid withdrawal. There's been a number of campaigns and even like freeway posters of legalized cannabis because it's going to help with the opioid epidemic. The data around that really hasn't played out, but it also doesn't seem to have a negative impact in patients being maintained in treatment for medication for opioid use disorder. And it's a whole other talk about cannabis and pain that is outside of the scope of our session today, but I just want to highlight that it is a common thing that patients will use to self-manage pain. So Alexa has been using cannabis daily for the last 5 years to self-manage her chronic pain and insomnia. You assess for cannabis use disorder, and she does end up meeting a mild cannabis use disorder criteria. She's developed tolerance, she has withdrawal when she doesn't use it, and she's also started to notice that she's using more than she'd like on some days. She does not want to discontinue cannabis use completely, but she's open to reducing if there are other options to help her with pain and sleep. And so you use that as an opportunity to open the door on a conversation of a comprehensive pain management plan and other strategies for managing her insomnia. So I want to wrap up this section by kind of reviewing my general approach. What do I think? What's my framework working with patients who use multiple substances, and which has really become the rule rather than the exception, that people are using multiple things. I think it's very important to start by exploring patient perceptions about concurrent substance use. Are there benefits that they get out of using that substance? What are the perceived benefits that they have? What about any perceived harms? Have they noticed any negative impacts of using that second substance? And then, do they have any desire to change the use of that substance or the use patterns? I think it's also important to assess for a second substance use disorder. Not all substance use is a substance use disorder, but going back to those DSM-5 criteria, is this something that someone is using in higher amounts than they'd like to? Is it causing functional impairment? Are they having tolerance and withdrawal? I think it's very important because if someone, especially if they're meeting moderate to severe substance use disorder, they may need separate treatment for that second substance use disorder, whether that's different medications, behavioral therapy, or counseling. And that can be an opportunity to provide education and support for patients around that. And then treat based on the patient's goals. Consider a harm reduction approach for those not ready to discontinue use. And the number one takeaway, if you take away one thing from this portion of the talk, is prioritize continuation of buprenorphine and continued engagement in treatment for opioid use disorder. In all of these cases and all of these patients, they do better if maintained on medication for opioid use disorder. That helps protect them from negative outcomes, even if it isn't specifically treating the use of that second substance. Being stable on buprenorphine is much safer in all of these cases for all of these patients than should they have a return to use of an illicit opioid such as fentanyl.